Hello, everybody. I shall now be talking on the approach to the patient with hypertension, what the doctor seeks for in dealing with the patient with high blood pressure. Now, we shall go through what is the definition of hypertension, how it comes about, what sort of assessment the doctor seeks clinically. That means listening to the history and in examining the patient, what are the important points the doctor seeks, what are the tests the patient needs to go through, and how is such a patient treated. Let's start by trying to answer three important questions. What is normal and what is abnormal blood pressure? When do we start treating the patient with hypertension? And what level of blood pressure are we trying to reach? This comes from the definition given by the American College of Cardiology and the American Heart Association, and it is very simple. Hypertension is considered as a pressure that is above 130 by 80. And if the blood pressure is above 140 by 90, that is said to be stage 2 hypertension. So only two stages of hypertension starting from 130 by 80. However, note that while hypertension is above 130 by 80, the Americans define normal blood pressure as less than 120 by 80, with the level in between said to be elevated blood pressure. The Europeans have a different, slightly more complex calculation. For them, hypertension starts above 140 by 90. So their cutoff for the development of hypertension is slightly higher than that for the Americans. The Europeans start at 140 by 90, and they have three grades of hypertension, each increasing by 20 millimeters mercury or 10 millimeters diastolic, 20 millimeter systolic elevation per stage, and 10 millimeter diastolic elevation per stage. Note that although they disagree on when hypertension starts, the Europeans having a higher threshold, the Europeans are also in agreement that the best blood pressure to have is below 120 by 80. However, the Europeans call it optimal, not normal like the Americans. So it gets a bit confusing when you go into details. But as a general overview, both are in agreement that the blood pressure is best if it's less than 120 by 80 in a normal person. Note that we are not talking about the treated patient, but in the normal person, if the blood pressure is below 120 by 80, that is best. And if it is above 130 by 80 or 140 by 90, then hypertension starts, depending on whether you are using the American or European classification. Now, an important point is brought up in the European definition, in that depending on how you measure, blood pressure is slightly different. We are used to the definition of blood pressure as that measured in the doctor's office when the patient comes. And for that, the Europeans call it office blood pressure, and their cut-off level is 140 by 90. However, if you measure blood pressure only during the daytime or only during the nighttime or throughout the 24-hour period, then you get slightly more different reading for what is normal and abnormal. For example, if you measure only blood pressure during the sleeping hours, then anything above 120 by 70 is considered abnormal, while the average of a 24-hour recording above 130 by 80 is abnormal. And if the patient measures the blood pressure himself at home, then the abnormality starts above 135/85. So the important point to highlight here is that blood pressure measured in different ways under different circumstances will be very different. The Europeans also show that the threshold for what is abnormal is also slightly different depending on the age of the patient. The definition of hypertension by the European guidelines would be above 140 by 90, and that is for patients of all age groups with all clinical Now, while the definition of what is hypertension is slightly different according to the Americans or the European definition, the reason we treat the patient and how we treat the patient is actually very similar. In deciding when we start hypertension treatment, it is important for us to remember the principles. The principle is that hypertension leads to cerebrovascular disease like stroke, ischemic heart disease like angina, heart attack. It leads to heart failure and renal failure. So these are the conditions that come about from hypertension. And when we treat hypertension, our aim is actually to reduce the future occurrence of these diseases. We want to prevent the abnormal effects from these diseases that the patient may suffer if the hypertension is untreated. It is, however, very important to remember that the development of these clinical diseases also depends on other factors besides hypertension. Now, this is shown elegantly in this chart that the risk of future disease depends not just on the level of blood pressure, but on the presence of other risk factors, depends on whether the patient has metabolic syndrome, whether the patient already has organ damage, or the patient has diabetes. In patients with established disease, whether renal disease, cerebrovascular, and cardiovascular disease, if they already have disease, then whatever the level of blood pressure, they are actually at very high risk to get a subsequent worsening of the disease, another event related to the disease. So it's very important for us to look at the risk of future disease when talking about the hypertensive patient. It is not just about the level of blood pressure, it is actually about the risk of developing clinical disease. What are the risk factors that can affect patients and cause them to develop cardiovascular, renal, cerebrovascular disease? Well, in addition to blood pressure, is their age, whether they smoke, their lipid levels, whether they are diabetic, whether they are obese, whether they have a family history of these diseases. The presence of diabetes would greatly increase the likelihood of future disease. If the patient already has evidence of organ damage, like left ventricular hypertrophy, thickening of the muscles of the left ventricle, if there is evidence of a plaque in the carotid artery as measured by wall thickening, if the renal function is already abnormal as evidenced by an increased creatinine, if there is microalbumin in the urine, these are all indicators of organ damage. And once there's organ damage, they are more likely to get clinical disease later on. Now, if the patient has established disease for the cerebrovascular system, it is having a previous cerebrovascular accident or stroke, a transient ischemic attack. For the heart, cardiovascular system, it is having a previous myocardial infarction, heart failure, and ischemic heart disease. The patients with previous evidence of renal dysfunction, with peripheral artery disease, and with retinopathy like hemorrhages, exudates, and papilledema. Once there is evidence of disease of these organ systems, the likelihood of patient getting another bad event is much higher, regardless of the blood pressure. Therefore, it is important to always remember that in hypertension, we must assess the future likelihood of getting adverse clinical events. We have to look at the risk factors for the development of adverse future cardiovascular events. We must look for evidence of organ damage. We must look whether there is diabetes, and we must look to see whether the patient has had established atherosclerotic or renal disease. And if any of these are present, then the management and approach to the patient will be very different from the person without these risk factors. The treatment aim is therefore not just to reach a certain blood pressure level. The treatment aim is to reverse whatever organ damage there is and to prevent the development of disease. It is very important to remember that these are the aims of treatment, not to reach some arbitrary blood pressure level. All guidelines agree on the importance of risk factor assessment. So we must look for the risk factors and seek to control and normalize them. We must look for organ damage, and we must look to see that the clinical disease is present on every patient before deciding on how we should treat. Treatment, therefore, depends not just on blood pressure levels, and this is the most important message that has to be picked up. The treatment of hypertension is to prevent future adverse events, and we have to look at the risk factors for these events. We have to look for organ damage that can increase the incidence of these events, and we must look to see that the disease is already present because this will have a great effect on whether the events will occur. Now, what treated blood pressure level should we target for? The American guidelines is very simple. The threshold of treatment is above 130 by 80, and the target essentially is below 130 by 80. So above 130 by 80, we should try to treat if appropriate and bring it below that level. The Europeans are generally similar, giving a blood pressure target to reach of under 130 by 80. However, the Europeans in the older population group allow for a slightly higher target level, below 140 by 80. In certain patients, in elderly patients, and in their definition, those with chronic kidney disease uh, should be targeted to reach less than 140 by 80. I think to simplify matters, it would be reasonable to consider here in Malaysia that any patient with a blood pressure level above 140 by 90 is hypertensive, and when we treat, we should try to reach a target that is below 130 by 80, and for older patients, perhaps tolerate a slightly higher level and target below 140 by 80. Remember, it is not a good idea to treat to excessively low blood pressure levels such as below 120 by 80. Now, for the ordinary person, healthy, not on treatment, if the blood pressure is naturally below 120 by 80, it is actually a good thing. He will be at lower likelihood of developing organ damage and future disease. However, if we are to treat, we should not target such low levels because of the side effects of the drugs. And targeting these low levels may actually worsen the outcome for the patient. There is some evidence for that. We now come to the pathophysiology of hypertension. Now, blood pressure physics principle or any pressure is the product of flow and resistance. Flow times resistance is pressure. Therefore, in the circulatory system, the blood pressure is actually the product of the cardiac output and the total peripheral resistance. Cardiac output is the product of the stroke volume and heart rate. So stroke volume times heart rate times resistance is the blood pressure. Once we see this equation, it is quite easy to see what elevates the blood pressure. Anything that elevates the resistance, anything that increases vasoconstriction will increase the blood pressure. Anything that increases the heart rate, the sympathetic nervous system will increase the blood pressure. And anything that causes volume increase, fluid retention, will increase the stroke volume and therefore the blood pressure. So it is easy to understand from the principle of physics why elevated blood pressure occurs. However, it is very difficult to identify a single risk factor for a particular patient if they come with elevated blood pressure. It is often a combination of vasoconstriction, sympathetic overdrive, and fluid overload. And most of them have a history of hypertension, and most of them are in the older age group. So, as a result of aging, the circulatory system changes. There is some degree of vasoconstriction, not enough relaxation of the blood vessels. Sympathetic stimulation is not so well tolerated, and there is some degree of fluid retention. So hypertension then is more common in the older age group. As to which particular cause is prominent, dominant, or important, it is not difficult. It is very difficult to work out in the majority. 90 to 95% of the patients with hypertension that we see, they actually have what we call primary, essential, or idiopathic hypertension. We cannot identify a single causative factor. They are usually older patients with a family history, with lifestyle inappropriateness, such as they do not exercise enough, they take too much salt, and they are obese. So all these people are described as having essential or idiopathic hypertension, accounting for the great majority of patients with hypertension. Now, in 5 to 10% of patients with hypertension, usually in the younger group of patients, or in those whose hypertension is difficult to control, they have an underlying renal disease. They sometimes have an endocrine disease like Conn syndrome or hyperaldosteronism, Cushing syndrome. They have pheochromocytoma, hyper or hypothyroidism, acromegaly. These conditions can all present as elevated blood pressure levels. Vascular abnormalities like coarctation of the aorta or renal artery stenosis will also cause hypertension, as can ingestion of drugs or toxins like excessive amounts of alcohol, like the analgesics, non-steroidals, and the toxic inhibitors will both elevate blood pressure levels, leading to hypertension, as can oral contraceptives. So there are drugs one has to think about. There are endocrine abnormalities, there are vascular abnormalities, all of which can cause hypertension. And these are the secondary hypertension. It is important to identify them because once identified, the underlying condition can be corrected and the patient can be cured of hypertension. This system is important to remember, the renin-angiotensin system in hypertension, because many of the pathophysiological processes and treatment can be explained from this system. That in our body, angiotensin-nogen is converted to angiotensin 1 by renin, and angiotensin 1 becomes angiotensin 2 through the angiotensin converting enzyme. Angiotensin 2 is a vasoconstrictor, leading to vasoconstriction, which will increase resistance, increasing afterload, elevating blood pressure levels. Angiotensin 2 also leads to the stimulation of the hormone aldosterone, which leads to water and sodium retention, and this also increases volume and therefore causes hypertension. This is